Hello, and welcome to Clinical Updates, Cardiac Management, DM Clinical Research Network, and Brain Manifestations of DM1. I'm Mike Knoppen, the MDF Program Director. This session is part of the DM Professional track. It is intended for clinicians, researchers, and industry experts, but all are welcome. The session will be available for viewing after the conference at the MDF Digital Academy. You can reach that at www.myotonic.org/digital-academy. I am delighted to introduce our presenters for this session today. First, Dr. Nicholas E. Johnson, who's an associate professor, division chief of neuromuscular and vice chair of research in the Department of Neurology at Virginia Commonwealth University, with a focus in inherited neuromuscular disorders. He obtained his medical degree at the University of Arizona and completed his neurology residency and combined fellowship in neuromuscular medicine and experimental therapeutics at the University of Rochester. His laboratory is focused on identifying the pathogenesis of myotonic dystrophy, the limb-girdle muscular dystrophies, and facioscapulohumeral muscular dystrophy, and identifying appropriate clinical endpoints for these conditions. Dr. Johnson conducts therapeutic trials in many other inherited nerve and muscle disorders, and he will be speaking today about the DM Clinical Research Network, or DMCRN. After that, we will hear from Dr. Pradeep Mammen, who over the past 17 years has established himself as a clinician scientist with a unique ability to traverse between the clinical and scientific spheres with relative ease. In addition to Dr. Mammen's clinical acuity and extensive expertise in clinical heart failure, VAD, heart transplantation, his scientific accomplishments include undertaking and leading scientific research studies in a highly collaborative and productive manner. Currently, he serves as an associate professor of medicine at UT Southwestern Medical Center and holds the Alfred W. Harris, MD Professorship in Cardiology. Dr. Mammen serves as the co-director of the UT Southwestern Senator Paul D. Wellstone Muscular Dystrophy Specialized Research Center and the director for translational research for the Advanced Heart Failure and Transplant Cardiology program at UT Southwestern. Since joining that illustrious faculty, Dr. Mammen has successfully administered various grants, formed strong collaborations with key clinicians and scientists such as himself, and discovered a novel signaling pathway within myocytes, and has produced 66 high-quality, peer-reviewed publications to date. Today, he will be speaking with us about cardiac management for DM. Our final speaker today will be Dr. Peg Nopoulos, professor of psychiatry, pediatrics, and neurology. She is the Paul W. Penningroth Chair and DEO and Chair of the Department of Psychiatry at the University of Iowa Hospitals in Iowa City, Iowa. Dr. Nopoulos is a physician scientist whose research focuses on the study of brain and behavior using state-of-the-art neuroimaging techniques, specifically magnetic resonance imaging, or MRI. Dr. Nopoulos has a special interest in neurogenetics and has research programs in Huntington's disease, myotonic dystrophy type 1, and spinocerebellar ataxia. She studies the effects of the Huntington's gene on brain development and is director of the Kids HD, now Change HD, and Kids JHD programs. She is the primary investigator of the only prospective longitudinal study of brain and muscle MRI measures in adult onset DM1, which is designed to evaluate the potential use of MRI muscle and brain measures in clinical trials. She'll be speaking with us today about the latest developments in that work. But first, we will welcome Dr. Nick Johnson to kick things off. Please enjoy the presentation.
Good day. My name is Nick Johnson. I'm Vice Chair of Research and Associate Professor in the Department of Neurology at Virginia Commonwealth University. And I'm here to talk to you about the work that's been going on in the Myotonic Dystrophy Clinical Research Network. Before I forget, a big thanks to our sponsors, MDA for supporting the clinical trial infrastructure for the past 6+ years, the FDA and Myotonic Dystrophy foundations for being the original co-sponsors for the and DM1 study, and then our partners in the industry who've joined the pre-competitive collaboration, Dyne Therapeutics, Avidity Biosciences, and Triplet Therapeutics. Without this team and the amount of support that we've received, we couldn't have made the progress that we've made so far within the network. So what are the goals of the network? Number one, we're interested in understanding the progression of myotonic dystrophy, trying to understand how to measure this progression using clinical outcome assessments and patient-reported outcomes. We're very interested in developing biomarkers for drug response. And then, it's not a very sexy goal, but preparing individuals at sites with myotonic dystrophy and sites themselves for upcoming therapeutic trials. That's kind of the nitty-gritty bedrock upon which, this community is going to see successful therapeutic trials. Sites are ready, patients are ready, investigators are ready, and we know what's coming and know how to prepare for it. Couldn't do this without this rock star coordinating team, lead evaluators, Kate Eichinger at the University of Rochester, the lead coordinators in project management, Jeannie Dectebroom at the University of Rochester, Jessica St. Romain at Virginia Commonwealth University, and the grants and contracts administrator is Aaron Despain at VCU. Here you look at the map of our current sites. You can see we've got 11 sites in the United States, 5 in Europe. I know that we're on our way to adding a site as well in New Zealand. And what has the network done? What's been happening in the network since its inception at the University of Rochester? So the original single-site natural history study was done at the University of Rochester. There was a follow-on 6-site natural history study involving those sites there and 100 patients. And the most recent therapeutic trial in DM1, now 5 or 6 years ago, used the DMCRN sites. What have we learned? This is a vector plot. Many of you have seen these data before, courtesy of Jeff Statland, showing an individual vector for each of those participants. And you can see that the overall rate of change, remarkably similar between the single site and the multi-site study, about 6% on a 30-foot walk, run, or 10-meter go, depending on which metric system you're using or unit system you're using. Even though there's heterogeneous progression, we think that there's a clue within these data to suggest that there are people who likely are remarkably stable over the course of 12-month period, but there are other people who are prone to progression over that time. And we don't just see this on ambulatory measures, we see this on measures of forced vital capacity or respiratory function. Same vector plot idea here, looking at forced vital capacity, and you can see, again, there's some stability, particularly if you're above 100% predicted or within that range. Once you drop below 80% predicted, the rate of progression is actually remarkably expedient. So heterogeneous disease, everybody knows that myotonic dystrophy is. And so here, these prior studies are simply demonstrating that heterogeneous progression that we see. That, if you're looking at across the entire population, you're at about 5%, 5 to 6% rate of change on an individual measure, which makes clinical trial design challenging. The key takeaways from the prior studies, DM1 is a heterogeneous disease. As I said, the clinical outcome assessments, I didn't show you those data, but they can be done in a reliable manner. There's a short list of clinical outcomes that one might consider a primary clinical primary outcome in a therapeutic trial: 10-meter walk, run, grip strength, myotonia, respiratory function. Most importantly is that prior performance on an outcome measure may predict future performance. And if you think about kind of a stylized model of what you might hope to see over a 12 to 24-month period, you're not looking for a low, that blue line down there where you're not going to see any change at all over that time. A measure that captures a high rate of change in the first 6 months on those participants might not be ideal as well, because it's possible that the disease modification may take a longer amount of time to see an effect. Really looking for that sweet spot, that midpoint there, where you see a modest amount of change, more than the overall population, and that can be captured over 12 months. So these prior studies have really spoken to several gaps that we aim to close through the network. One, better predicting rate of progression by prior performance. So there's clues in those vector plots that there are some participants that you think, well, maybe these ones are the ones that you could suggest, they might be the ideal candidates for a therapeutic trial. So can we statistically model that and really definitively say what's the ideal trial population? We want to identify other predictors of severity. It's a complicated heterogeneous disease. If it was simply the repeat length, everybody would progress at the same rate. With that, we know that that's not true. So what are some of the other predictors of severity? And we want to optimize biomarker collection as well, and make sure that that's trial ready as well. And of course, approaching therapeutic trials have provided some urgency to these goals. So the current study is a study called NDM1. The goal of that study is to characterize DM1 severity and disease progression over 2 years in a large cohort, about 700 patients, and to determine basal levels of impairment on standardized measures of motor function and muscle strength and patient-reported outcomes. And then, like I said, really to test for patient characteristics at baseline that might predict subsequent progression. So that's a big goal. We think that's an important thing to do, and really is a cornerstone of preparing for late-stage registration trials in this indication. We also are aiming to complete the development of muscle RNA alternate splicing events as biomarkers of DM1 severity. Charles Thornton and his team at the University of Rochester have done an outstanding amount of work in this area, optimizing this, preparing patients for this, using the smallest needles that we can identify to capture the RNA, and looking at precision measures of RNA splicing. So looking at determining the test-retest reliability of splicing biomarkers using optimized sample collection, assessing between run variants of splicing biomarkers at different centers. Again, trying to get this to a place where it's readily exportable and anybody in the community could use this. We're not going to talk any more about that today, and we're also not going to talk any more about preparing to perform a GWAS study to understand determinants of disease severity, because that's a follow-on study. And of course, this study was originally founded by the FDA Orphan Product Division. It's done with the expectation that it will provide robust natural history data to support drug approval using FDA's guidance on natural history studies. Where are we at today? Well, to be honest, we're a little bit behind where we want to be. You can see there we're just about 250 patients enrolled overall in the study. You can see that many of those participants, if you kind of map it out between the 0 and 12 month visits and even the 24-month, that many of those patients have enrolled quite recently. But that, there are patients who've gone through, about 61 have gone through 12 months and about 17 through 24. And so we're the entire group is really pushing to get us over the hump and really enroll these patients in these clinical trials, or in this clinical trial. Looking at that initial 249 patients, about 57% are female, the 88% are Caucasian, for both race and ethnicity. It's a pretty mixed group, about 22% with college degrees, 28% with high school degrees, and then a few with professional graduate degrees. One of the things that we're interested in the series of data I'm going to show you are just looking at some of the baseline distribution of the characteristics of patients who are enrolling in the study. Today, again, the first here you can see, depending on when these studies were, or when these statistics were run, 230 to 240 plus patients. So the age at symptom onset, you can see there's a pretty good peak there between what looks to be between 5 and 20 or so. A few late onset patients enrolled in the study, you can see above 50 to 70 there. The mean age of onset overall is about 25. But you can see there's quite a wide distribution in terms of the age of the patients who are actually enrolled in the study. And as a reminder, one of the really, it's a pretty broad inclusion exclusion criteria, but one of the things is that participants have to be over the age of 18. before enrollment. You can see the mean age there is about 43, but again, wide distribution of patients enrolled in the study here. Okay, so we looked at that data. One of the things we're really interested in looking at is to see, what's the distribution of progression on that 10-meter walk in 5 seconds. Is kind of maybe the bottom line there. There's a large number of patients there that have enrolled with a 10-meter walk time below 5 seconds, but also a pretty good distribution of patients with a 10-meter walk time over 5 seconds. So the mean 10-meter walk time in this cohort so far is about 6 seconds or so. And then again, looking at MERS, so a way of rating strength, the vast majority of patients have a MERS of 4, but a pretty broad distribution between 1 and 5 nonetheless. So this is for a very large population-based study. These are the kind of things that we're hoping to see naturally occur as part of the enrollment. We want to see a broad distribution of age, strength, symptom onset, because we think those will help us provide the overall patient characteristics that are going to be helpful. Here's some additional data. This is looking at the correlation between the 10-meter walk run and the MERS. As expected, not a very strong correlation there between those two. And then finally, looking at the baseline data of the forced vital capacity. The mean percent predicted so far is about 70%, which is actually lower than what I thought it would be. You can see there's a pretty big group there. And so we expect to see within that group a fairly sizable amount of progression over that 24-month period. So COVID-19 happened. It's happening now. I'm recording this video to you from my house, and I wish I could be there meeting with everybody and talking about this in person. It has had a significant impact on the study. You can see there that we were able to widen our visit windows, but despite that widening, we had 2 patients who missed 3-month visits, 31 missed 12-month visits, 11 at 24 months. In some total of 700 patients, this is not going to be a huge amount, but it is a significant amount, particularly as the study is getting off the ground. Many of our sites have had difficulty with forced vital capacities, performing those in person. And so that, even though I said that we've got a large distribution there, there's a gap in those data. We're hoping to be able to come back up. And, one of the goals of the network is to prepare sites for clinical trials. And we lost site expertise during COVID-19. We've lost PIs, we've lost clinical evaluators, which are just invaluable. And we've lost clinical research coordinators, same thing, incredibly valuable to the study. And so, I think it happened at a time early enough in the study that we'll be able to recover, that the therapeutic trials are unlikely to be impacted. We still got good teams at these sites, but I think it's just important to recognize for a minute that COVID-19 did happen. We've done our best to accommodate. Look forward to putting our best foot forward as we progress, and hopefully this meeting is in person next year. Through sponsorship, we've been able to initiate a pilot program to add small components of research based on investigator desire, as well as things that are really going to move the field forward and prepare us for clinical trials. And so we did have a pilot award process. Kate Eichinger and Team DeWonk have a pilot for actigraphy in DM1. Donovan Lott is doing a pilot looking at exercise in DM1. And Jacinth Sampson is doing a pilot looking at the impact of COVID-19 in DM1. So I think I'm looking forward to seeing those studies go on. I continue to fill out our knowledge of natural history and trial preparedness in this disease. We do have a future study coming, just so you're aware, Aspire DM1 is supported by Novartis Gene Therapy. It's looking to enroll 30 children with CDM from ages 0 to 3, 20 children with childhood DM1 from 1 to 4 years, with a 12-month follow-up period. So that study should get underway and enroll in the fall. So moving forward, we're continuing to do data monitoring at sites, soft flux every 100 patients that are enrolled. The FVC completion is now expected to change with remote tools. I didn't mention that earlier, but we've added remote spirometry as an option for sites who are unable to accomplish it on site. We have a DMCR investigator meeting late October 2020, possibly in person. Fingers crossed, we'll see. And then, we're enrolling patients. We need all the investigators to enroll patients and look forward to continuing to present data as the study unfolds further and we continue to progress. That is it. Thanks everyone for your time and attention.
Good day. My name is Pradeep Mammen. I'm a professor of internal medicine here at UT Southwestern Medical Center. And I'm a board certified heart failure VAD transplant cardiologist with particular expertise in the management of cardiovascular diseases in muscular dystrophies. And we will begin. Let me share my slides here. Very good. So for the next 20 to 30 minutes, I'm going to be talking about some of the cardiovascular manifestations that are seen in patients with myotonic dystrophy. These are my disclosure slides. This is an overview of my talk over the next 20 minutes. We're going to give you a very brief introduction about myotonic dystrophy, what are some of the cardiovascular effects of myotonic dystrophy, how do we assess and manage cardiomyopathies in myotonic dystrophy, how do we manage electrical abnormalities in myotonic dystrophies, and then I'll make some concluding remarks and take-home messages. So myotonic dystrophy, as the audience is well aware, is an autosomal dominant disease. There are two types, type 1 and type 2. Type 1 is related to CTG repeats in a gene called the DMPK gene, while type 2, which is much rarer, are these repeats of CCTG in a gene called the CNBP gene. In both of these subtypes, it is viewed as a systemic disease. Some of the brief differences between myotonic dystrophy type 1 and type 2 is that in type 1, it's almost universal in terms of who may develop a myotonic dystrophy, while myotonic dystrophy type 2 tends to be limited to patients of Northern European descent. There is a congenital form of myotonic dystrophy type 1, while type 2, that is absent. One of the main issues with these patients are development of respiratory muscle weakness, especially the diaphragm. You see this very commonly in type 1 disease, rarely in type 2. And then obviously cardiovascular disease is very prominent in myotonic dystrophy type 1, while it's nearly absent, usually it's absent or less severe in type 2. So this is a systemic disease, as I mentioned, and there has been a recent predictive model that models survival in patients with myotonic dystrophy, and this was published in JAMA Neurology, where they assign points to various characteristics of patients. So the older patients they got more points. They developed diabetes. They have difficulty walking. If they were more bradycardic, if they were hypotensive. So we have a point scale here from 0 to 20. And when they looked at these point scales and predicted 10-year survival, so the y-axis here is predicted 10-year survival, and the x-axis is the simplified scoring system. So the more points you get, the lower your 10-year survival is compared to very low scores where your 10-year survival is actually very, very good. Put it another way, where they grouped the different scores from 0 to 4 to 14 to 20, you can see that the higher the number of points, the lower your survival over an extended period of time. And this is an important aspect to understand, because what limits survival is usually related to cardiovascular or respiratory issues in the majority of these patients. And so to highlight the development of cardiomyopathy is not uncommon in this population, and we'll talk about that here shortly, as well as arrhythmias is very common. And these events are cumulative over time. The problem in the management of cardiovascular issues related to myotonic dystrophy is many of these patients with myotonic dystrophy were frankly excluded from many of the large cardiovascular trials, both heart failure and arrhythmia trials. And there's limited number of very well-controlled randomized studies that help guide us in terms of management of cardiomyopathies in this population. And although there are some limited guidelines as to the best practices in cardiovascular care in this patient population, it is still limited. And so much of what we talk about is based on expert opinions. So one way to kind of get a more, a better understanding of how to treat these patients is really under one roof, have a very well protocolized approach to these patients. And that's what we did about 10 years ago in the UT Southwestern Neuromuscular Cardiomyopathy Clinic that was developed in 2010. And this clinic is directed by me, and the patients are evaluated in a very systematic way as we approach these patients. It's one of 6 adult neuromuscular cardiomyopathy clinics in the country. It's one of the largest. Today, we've evaluated a little over 950 patients, which averages about 6 to 10 patients a month. And our referrals initially were from our UT Southwestern pediatric and adult MDA clinics, but we've expanded our referral base to neurologists and cardiologists in all of North Texas and the surrounding states. They are seen in this clinic. As I mentioned, we systematically approach these patients. We clinically and biochemically phenotype each patient. We evaluate their cardiovascular status, their electrical status using EKGs and Holters. And imaging is a very important part of assessing the cardiovascular effects in this patient population. So what are some of the cardiovascular manifestations of myotonic dystrophy? So this was perhaps one of the largest collective studies looking at the various studies over the 90s to early 2000s of cardiovascular issues that occur in myotonic dystrophy. And the prevalence of arrhythmias and cardiomyopathy is highlighted here. So you can see for patients with atrial fibrillation to non-sustained VT ranges anywhere from 5 to 10% of the population that will have these arrhythmias. And in this meta-analysis, about 7% of the patients had a cardiomyopathy as defined with an LVEF less than 50% by echocardiogram. And I'll mention some of the flaws in this study a little later on here. So this was an outline developed by Beth McNally, who's now at Northwestern. And in general, this is the approach one should take when one assesses a myotonic dystrophy patient. So we know that patients who are high risk of cardiovascular disease are older patients, patients with increased CTG repeats, and peripheral muscle weakness. So these are kind of high-risk patients. So the first thing is you look at their EKG. If they have signs of PR prolongation or widening of the QRS voltages, almost universally, these patients should be referred to your EP colleagues to either undergo an EP study or, depending on the history, placement of a pacemaker or ICD. If the EKGs is completely normal, then it is recommended that we check an EKG at least every 6 months and monitor that along with a Holter monitor. Now, if they have signs of syncope or pre-syncope, well, that changes the ballgame, irrespective of what their baseline EKG shows, and they should almost universally be evaluated by your EP colleagues. And if there's a family history of arrhythmias or sudden death, they also should be referred to an EP, a physician, to evaluate their electrical properties. Evaluate imaging the heart. But there are two main modalities, echo and cardiac MRI. And I will demonstrate that we feel that cardiac MRI is a superior way to image the heart, and I will give some arguments to support that. But if you have a depressed ejection fraction and or the presence of delayed enhancement or signs of scarring, which is seen by cardiac MRI, you should be very aggressive in managing these patients. They have a cardiomyopathy, and you start them on beta blockers, ACE inhibitors, and I will outline my approach to these patients. And of course, older myotonic dystrophies may also have concomitant coronary artery disease, and you need to evaluate that. If they have completely normal cardiac function, one should reassess their cardiac function about every year to determine whether LV dysfunction is occurring. This is a chart I put together to summarize the various tools and diagnostic tools that we use to assess these patients. So biochemically, we assess all these patients. We get a significant blood work to allow us to calculate their Seattle heart failure score, to give us some prognostic information of their cardiovascular disease. We look at how their thyroid is doing, what's their hemoglobin A1C, because myotonic dystrophy patients at risk for developing diabetes. And we also follow their cardiac and inflammatory biomarkers as outlined here. It's very important that a patient with myotonic dystrophy is genetically sequenced, because as I mentioned earlier, the higher the number of repeats, the more likely that they're going to develop cardiovascular disease sometime in their lifetime. We assessed electrical properties with a baseline 12-lead EKG, a 48-hour Holter, and in select patients, we'll put loop monitors or a Medtronic reveal device to further evaluate their arrhythmias or potential arrhythmias. Imaging, as I mentioned, here at UT Southwestern, our gold standard, followed by many neuromuscular cardiomyopathy, neuromuscular cardiologists, is to use cardiac MRI. If they can undergo an MRI for a variety of reasons, a cardiac CT in our estimation is the next best thing. What we're trying to do is get quantitative numbers. An echocardiogram is notoriously inaccurate, but an MRI and cardiac CT is much more quantitative assessment of their cardiovascular function. And if our patients are able to walk, we get a 6-minute walk and or a cardiopulmonary stress test, which we can follow objectively their functional status over time. So development of a cardiomyopathy in myotonic dystrophy. So this is a recent review by Russo in the Journal of Cardiac Failure, where they looked at a variety of different studies. These are more relevant to the present date as evidenced here. And what I want to highlight is they determine LV systolic dysfunction by echocardiogram, and their EF cutoff was either 55 or 50%. And in general, the prevalence of LV systolic dysfunction or cardiomyopathy is about 10 to 20%, depending on which study you look at. And these studies are pretty large, from mid-100s to the largest was 406 patients. And in this study, they found a prevalence of 18.9% of the patient population had a cardiomyopathy. Why I keep emphasizing that cardiac MRI may be a better tool to assess the cardiomyopathies in patients with not only myotonic dystrophy, but all muscular dystrophies, is that the imaging quality is far more superior. Most patients with myotonic dystrophy, as well as neuromuscular disease, will have scoliosis, which hinders getting good echo windows, and MRI overcomes that. And you have far better assessment of the right ventricle by MRI than by echo. You can, one advantage by MRI is you can identify myocardial fibrosis, which you cannot identify by echo. And we know that presence of myocardial fibrosis in and by itself is a poor prognostic indication in these patients. Now, one thing to highlight is what is normal by MRI is different as compared to echo. So a normal ejection fraction on the left side, and this is based on large databases of assessing normal individuals, is 67% plus or minus 5 points. So the range of normal left ventricular ejection fraction is 62 to 72%, while by echo, what's considered normal is anything above 50, 55%. So a far more accurate way of looking at their cardiac function. So this is the algorithm that we've developed here at UT Southwestern using cardiac MRI as our imaging modality. And so normal LV ejection fraction, once again, is anything above 62%. And so if someone has normal LV ejection fraction, but no signs of delayed enhancement, we start these patients on an ACE inhibitor, like enalapril or lisinopril. If they have normal ejection fraction, but presence of delayed enhancement, it's recommended we start an ACE inhibitor plus an MRA, a mineralocorticoid receptor antagonist, like spironolactone or eplerenone. And I'll be listing all these medications in a table here in the next couple slides. Now, if they have abnormal left ventricular ejection fraction, but no delayed enhancement, you start beta blockers and ACE inhibitors. While if they have abnormal left ventricular ejection fraction with presence of delayed enhancement, then it's beta blockers, ACE inhibitors, and MRAs. Now, if they fail to reverse remodel, meaning improve their cardiac function on these medications, then we swap the ACE inhibitor for an ARNI, like Entresto, which has become a recent medication that's been shown to reduce mortality and morbidity in patients with cardiomyopathy. The problem with ARNI drugs is that they also result in, they're pretty potent drugs that lower your blood pressure. And many patients with myotonic dystrophy have problems with hypotension. So one needs to be careful about adding this medication to these patients. So this is the table in 2021, our approach and medical treatment of these patients. So what's highlighted in red are really the main staple, the main drugs that we use to stabilize someone who has a cardiomyopathy. So beta blockers, and there are 3 beta blockers in particular, they're FDA approved for treatment of a cardiomyopathy, and that is carvedilol, toprol, or bisoprolol. The next set of drugs are ACE inhibitors or ARBs. So ACE inhibitors are lisinopril, enalapril, captopril, and if they have a cough, one can switch these patients to an ARB like candesartan or valsartan. And then aldosterone inhibitors like spironolactone or eplerenone rounds up the 3 main medications we use to treat their cardiomyopathies. As I mentioned, ARNIs or Entresto is a combination medication. It's made up of valsartan and neprilysin inhibitor. This medication has been shown to lower morbidity and mortality in patients with cardiomyopathy. And in the recent guidelines, it has actually replaced ACE inhibitors of the drug of choice. But as I mentioned earlier, it does have a more profound effect on blood pressure, and that is something that one has to be very mindful in this patient population. Sglta2 inhibitors, these are medications traditionally used to treat diabetics, but these medications have been shown in both diabetics and non-diabetics who who have a cardiomyopathy to improve mortality, morbidity. And the two particular drugs are dapagliflozin and empagliflozin. The other drugs like Bidil and diuretics can be used on symptomatic patients. It's not always used. Pacemakers, defibrillators, and BiV ICDs are also used in this population, and we'll talk about it when I talk more about management of the arrhythmias. Now, I put here Lvads and heart transplantation. These are options for select patients with myotonic dystrophy. In general, it's about 1% to 2% of patients with myotonic dystrophy have such significant cardiomyopathies and arrhythmias and that are not controlled with medications that we have to look at these more advanced therapies like LVAD or heart transplantation. I currently follow about 150 patients with myotonic dystrophy, and we have 2 patients who've undergone heart transplantation for that. So it's a very limited number of patients that qualify for these really advanced therapies. So arrhythmias and myotonic dystrophies, this is the mainstay of what affects many patients with myotonic dystrophy. So what are some of the arrhythmias that we see? Well, developing AV block, first degree block, second degree block, or third degree block are important aspects. Third degree block is essentially a medical emergency, and one has to quickly place a pacemaker in these patients. Atrial arrhythmias, about 25 to 50% of the patient population will develop atrial arrhythmias over their lifetime. Ventricular arrhythmias have been noted in patients with myotonic dystrophy, but it's a small percentage, between 1 and 5% will have sustained ventricular arrhythmias, and this often can lead to sudden death. And so one has to be very mindful of that. I should also say about AV block. AV block is another major reason why many of these patients do have sudden death, because it goes unrecognized and patients drop dead because they go into third degree AV block. So how do we monitor the conduction system in these patients? Well, as I mentioned, a 12-lead EKG is important to do about every 6 months. And what you're looking for is their PR and Qrs intervals. And I'll go through that here shortly. We also do, in general, a 48-hour Holter about once a year to look, are they having silent pauses that may make one be worried about sudden death. In select patients, we'll put a 30-day event monitor if we have concerns about arrhythmias. And then implantation of these Medtronic link devices enables one to monitor their rhythm over a period of several years. And this has become more and more popular among EP physicians managing many of these myotonic dystrophy patients. So as I mentioned about AV conduction disease, so looking at the time it takes for a signal to go from the SA node to the AV node is called the PR interval. And if you start having a PR interval greater than 200 milliseconds, that should be a flag that pathway is being fibrosed down and they may need to get a pacemaker in the near future. The other thing that we look at is their QRS interval. So which may relate to development of right bundle branch block or left bundle branch block, which is also a poor prognostic indication in patients with myotonic dystrophy. I mentioned about this Medtronic link device. So it's about the size of a battery, and it's implanted in the left upper part of the chest. It can be done in the office, although most EP physicians will place this in the CATS lab. It's a very simple procedure. It's right underneath the skin, and it can last there for several months to years. And we've now started putting in these devices if we have a high index of suspicion of atrial arrhythmias, but we're not able to detect that by standard Holter monitors. And I believe Johns Hopkins is doing a clinical trial looking at the utility of Medtronic link devices in myotonic dystrophy patients. So these devices, once they're implanted, they will download the data to a receiver, and the physician can assess it once a month to look at, is there any silent arrhythmias or AV block or pauses that wouldn't normally be able to be detected on a routine basis. So it's really been a real game changer in our evaluation of the arrhythmias that occur in myotonic dystrophy. Pacemakers, this is just a schematic of what the pacemaker looks like. It's placed in the left upper part of one's chest, and the wires are implanted, one usually in the atrium, one in the ventricle. If they meet certain criteria, they may get a third lead to bi-V pace these patients. Atrial arrhythmias, what are the types of atrial arrhythmias that we see in myotonic dystrophy? You can see anywhere from atrial flutter to atrial tachycardia to atrial fibrillation. Our first line usually is to try medications, beta blockers, in particular carvedilol or toprol, or antiarrhythmics like amiodarone, sotalol, or mixilotine. But more and more, we are reverting to RF radiofrequency ablation to essentially eliminate the arrhythmia and prevent long-term use of medications in this patient population. And so this essentially involves kind of mapping out where the arrhythmia is occurring, and then you kind of essentially zap that circuit and burn that circuit. So these arrhythmias arise in the atrium, they map it out, and then with a radiofrequency ablation, we can burn that circuit. And it's pretty successful, and the rate of reoccurrence of these arrhythmias, although it's not zero, it's pretty low. As I mentioned, ventricular arrhythmias can occur. It's not very common. It's about 1 to 5% of patients with myotonic dystrophy will have this. And they mainly present as premature ventricular contractions, ventricular tachycardia, or ventricular fibrillation. You can try beta blockers or antiarrhythmics if they're short runs like PVCs or non-sustained VT. But if you have sustained VT or VFib, which is sudden death, you're going to buy yourself an ICD, which is implanted. Of the 150 patients, as I mentioned, that I follow, I have 4 patients with implantable ICDs because of the concerns for recurrent VT or VFib. So this is another meta-analysis that was undertaken now about 10 years ago, looking at the prevalence of sudden death in patients with myotonic dystrophy. And I'm going to highlight the risk per year of sudden death. So the risk of sudden death per year is about 0.56%. The risk of having or implanting a pacemaker in a myotonic dystrophy is about 1% a year. And the risk of implanting an ICD is about 0.22% per year. And as you can see, so as a patient ages, that risk really does accumulate. So to conclude here, all myotonic dystrophy patients require a full cardiac evaluation, ideally by a cardiologist that has experience in managing arrhythmias as well as the cardiomyopathies. As I've shown you some data that in general, the prevalence of cardiomyopathy in this patient population is about 10 to 20%. Although in my population, using cardiac MRI, we find that about 30 to 40% of our population has some type of cardiomyopathy, predominantly subclinical, meaning they don't have signs of volume overload, but they do have depressed LV systolic function. One needs to closely monitor the electrical conduction in these patients by monitoring their EKG and looking at their PR intervals, performing Holter monitors at least once a year, and implantation of a Medtronic link device in select individuals. The prevalence of significant conduction disease is the major reason why patients have sudden death. And it's believed that the lifetime risk is somewhere around 40 to 50% of these patients will have some type of conduction or arrhythmic issues. Arrhythmias, as I mentioned, atrial arrhythmias occur in about 25 to 50% of patients. Our first line of treatment is medications, while more and more we're doing radiofrequency ablation. Ventricular arrhythmias is much less common. It's about 1 to 5%, but this leads to sudden death and needs to be assessed. Medications can be used if you have isolated PVCs or non-sustained VT, but if you have evidence of sustained VT, really you need to move towards an ICD. Rare cases you can ablate a ventricular arrhythmia, but for the most part, we implant bi-V ICDs or biventricular ICDs or just plain ICDs. Imaging, as I mentioned, cardiac MRI is really our preferred imaging tool over echocardiogram. Not only do you get more accurate assessments of their ejection fraction, but you also can determine whether they have myocardial fibrosis, which is a poor prognostic indication in patients with cardiomyopathy. And if they have evidence of LV dysfunction or cardiomyopathy, they really should be on these three staple medications: ACE inhibitors, aldosterone inhibitors, and beta blockers. With that, we're done here. I'm happy to answer any questions you may have. And thank you very much and have a good day.
This is Dr. Peg Nopoulos from the University of Iowa in Iowa City, Iowa. I wanted to thank the MDF for inviting me to speak about core brain symptoms of myotonic dystrophy. So some background: brain symptoms have become a focus of attention for myotonic dystrophy. These could be quite distressing to patients and families, and they're actually quite significant in their prevalence. It's important to understand the neurobiology of these symptoms. Are they primary disease manifestations, or are they secondary to the stress of having the disease? And really importantly, can they potentially be targets for therapeutic intervention? The Iowa DM1 brain study was funded by the NINDS and ran between 2015 and 2020. It's a single site at the University of Iowa, and it was a prospective longitudinal study of adult onset DM1. So I put that in all caps to emphasize the fact that it was a homogeneous group, did not include congenital or juvenile onset. This was adult onset DM1. We got baseline year 1 and year 2 visits and brain imaging, magnetic resonance imaging, MRI, and assessment of cognition, behavior, and motor function. So we wanted to evaluate what we consider to be core brain symptoms of DM1, and that included cognitive function, thinking skills, hypersomnolence, depression and anxiety, and apathy, which is diminished motivation. And we were interested in evaluating what the etiology of these symptoms were. Are they directly related to the brain pathology? Does that suggest that they're a primary manifestation of the disease, or are they secondary, not part of the brain pathology? And this work was recently published, first author being Jake Miller in the Frontiers of Neurology just a few months ago. This is the sample. We had 39 DM1, we had 71 controls. You can see the main age here, approximately in the mid-40s. The age at disease onset was defined by age at first motor symptom, and that was approximately mean 32 for this group. Disease duration was average about 12, but had a very wide range. And the muscle impairment rating scale on average was about 2, which really gives an indication of, in general, it's a pretty mild disease for these patients, and or it was early in the course of their disease. And so not a lot of patients that had severe disease. Median CTG repeat was 146. So we assessed cognitive function through standardized testing with the WAIS-4. This was full-scale IQ, a general measure, FSIQ. Depression and anxiety was quantified using the Beck Depression Inventory. And I want you to pay attention to the scale here, in particular, showing that 0 to 13 on that scale is minimal depression. As you go higher in the scale, you get mild, moderate, severe depression. Same thing with the Beck Anxiety Inventory, same kind of scoring. Sleep quality was assessed by the SCOPA, and we focused on the subscales D and summed those measures to identify specifically the hypersomnolence or daytime sleepiness score. Apathy was evaluated in 2 ways, and really important to make this point that oftentimes lack of motivation is something that patients with DM1 don't have insight into. So they're unlikely to accurately represent this symptom. And instead, family members or proxies may be more accurate and reliable at quantifying that measure. So we got both a proxy scale from a family member for a subset, but also self-report ratings. The brain measures, although there are many measures that may be abnormal in DM1, there's really a defining feature in terms of brain pathology for DM1. And that's the fact that the DM1 is a white matter disease, but it's not a measure of white matter volume or white matter lesions that really quantifies the disease pathology, but it's a measure of white matter microstructure, which is determined by diffusion tensor imaging, or DTI. So DTI measures the direction of motion of water molecules in the brain. So in the brain, this picture that you see up here on the left, that's white matters, which are made up of axon bundles. I think of them as electrical cords. The white matter is nicely organized, if it's healthy, into fiber bundles. And of course, if you have water moving along these cords, the fiber bundles, they're moving along all in one direction. One of the measures that we use for this is isotropy versus anisotropy. And you can see here that essentially, if a water molecule is allowed to freely diffuse in the space, that's completely isotropic. But if it has directionality to it, that is more anisotropic. And the measure that we use in DTI is called fractional anisotropy. And you can see here going on in the second graph on the right, FA is low in a sphere, but it's up to 1 if it's very directional. So the higher the FA, the more healthy the white matter bundles are in the brain. So higher FA is better. We first looked at just group differences between the patients and controls, and COVA controlling for age, sex, and their interactions. And then we have prediction models, because we were really interested in looking at potential relationships within these core brain symptoms. And most importantly, what was the relationship between these core symptoms and brain FA? If we feel like that there's a relationship, there is some support. Remember, this is all correlative work. We can't be mechanistic. But if we can show that brain pathology is directly correlated to symptom pathology, it suggests that there's a mechanistic connection between those two. So for the DTI, this is an image looking across the brain, and the color scheme is essentially just showing the differences between the 2 groups. And the color scale shows that the warmer colors have a higher beta, meaning there's a higher difference between the groups. And for the most part, just, you know, the 30,000 foot view is that there is differences that are quite global. They're very significant, and they're all over the brain. There does seem to be some predominance in the frontal lobe, but it really is a global, non-regional pathology. It's also directly related to CTG repeat. So the graph on the right looks at the relationship between estimated progenitor allele length, or EPAL. We looked at the log of this compared to cerebral FA. We see this direct relationship. The longer the mutation, the lower the FA, or the worse the brain pathology. It's also present early in disease course. We have a recent publication, the first author being Vanderplas, where we looked at pre-DM1 subjects. These are subjects who have not manifested motor disease, but they have the CTG repeat. And we see that the DTI and the FA measures are already significantly abnormal. It's present early in the course of disease. This all goes to show that the global FA is really the most sensitive, most useful measure to quantify brain pathology in DM1. So these are the brain or the core measures and the group differences. So panel A is full scale IQ. You can see in the green dots, that's the group mean for DM1. It's still in the normal range, but it's substantially lower than their age-matched control peers. Panel B is hypersomnolence. You can see that the DM1 patients have significantly higher scores. The Beck depression score is panel C. And you can see that that is indeed higher in DM1 patients, but I want you to pay attention to what that score is. On average, for the DM1 patients, it's a 9. And remember that in the scoring for the Beck depression inventory, scores from 0 to 13 were minimal depression. So even though there's a substantial difference, it really is clinically considered to be quite minimal. Beck anxiety score, same thing, much different, higher in the patients, but also in general, relatively mild. Showing here in the last panel is the self-report for apathy. Not shown is the proxy report. Both of them were significantly different in patients and control. So DM1 subjects have abnormalities in all measures. That was not at all unexpected. But what we were interested in looking at further was the relationship between symptoms first. Some of that is because deficits in cognitive skills may result in suboptimal coping strategies, may be difficult for patients to deal with the stress of a chronic disease, a degenerative disease. So we were interested to see whether cognitive deficit predicted higher measures of, in particular, things like depression and anxiety. So we ran predictive regression models, once again, controlling for age and sex. But what we wanted to do was look at these relationships. And this is the outcome for that. So in this prediction model, does full-scale IQ predict these other measures? And you can see that it does. It predicts depression and anxiety. And you can see here that the data for that regression model is negative, suggesting that the relationship is inverse. The lower the full-scale IQ, the higher the depression and anxiety. It was not predictive of apathy or hypersomnolence. So it was really specific to the depression and anxiety. We then looked at the prediction models for the relationship to brain pathology. So this is really the core question of the study, was to evaluate, are the changes that we see in the brain, are they directly reflective of the changes that we see in these core brain symptoms? And if yes, it really supports this notion that these brain symptoms are primary disease manifestations that are mediated by abnormal white matter. Here's the result from those analyses. So brain FA does predict full-scale IQ, proxy apathy, and hypersomnolence. And they predict it in a way that's expected, meaning that the worse the brain pathology, that means the lower the FA, the lower the IQ, and the higher the apathy, and the higher the hypersomnolence. FA did not predict depression, anxiety, or self-report apathy. So that was an important distinction. Importantly, because we know that IQ also drove depression and anxiety, the prediction models controlled for IQ. So we took that into account. So once again, brain pathology, FA measures predicted IQ, proxy report apathy, and hypersomnolence, but did not predict depression, anxiety, or apathy that was rated by the patients themselves. The interpretations are that the core symptoms of DM1 are a primary disease manifestation. It's due to brain pathology, white matter pathology, that leads to cognitive deficits, hypersomnolence, and apathy. Really important to think that this potentially could identify potential targets for disease-modifying therapies. Lots of work being done on therapies, including gene knockdown, as well as other therapies that have been considered potentially to be delivered directly to the CNS, but that these measures could be outcomes, markers for those kind of clinical trials, evaluating whether or not the therapies would be beneficial for these symptoms. The other interpretation is that depression and anxiety are not core symptoms of DM1. They're not related to the brain pathology. They're mild in nature. So this is not the kind of major depression that we see that's a separate disease in the general population. Remember, the Beck scores were elevated, but not to the range beyond minimal depression. It's likely secondary, these elevations in depression and anxiety, secondary to the stress of having a progressive disease. It's probably not different than if we were to look at patients with a diagnosis of cancer or some other severe chronic disease where the stress of dealing with that disease leads to depressive symptomatology. And then, of course, the factor for DM1 on top of that is that the greatest cognitive dysfunction were the patients that had the highest scores, and it may reflect poor coping strategy. It also suggests that depression and anxiety is not a target for DM1 therapies, but really the flip side of that, the good news, is that depression and anxiety should respond to typical treatments like counseling and antidepressants. The degree of depression that we see in these patients is not significant enough typically that you would use antidepressants, although some patients may benefit, but something in these ranges probably would benefit from counseling. Again, thank you to the Myotonic Dystrophy for allowing me to talk about these results, and have a great rest of the conference.